Hi.
Glad you could make it.
Thank you.
You okay?
Yeah, I left my backpack in someone's car.
That's okay. Did you have a good lunch?
It was delicious.
Yeah.
Yeah.
I'll give you a second to pull your stuff up. I honestly don't know how long this lecture's gonna last, so it may go the full 2 hours and may be done quicker. Do you guys have anything after this? Yeah, so you guys will be here anyways. This is the first time giving this lecture, so I don't know exactly how long it's gonna take me to go through all of it. So we'll just go ahead and get started. I'm Scott Interwitz. We'll be talking about bronchitis, bronchiolitis, and croup today. Some pretty simple, straightforward pulmonary upper respiratory stuff. Nothing too complex about it. A little background about me, I do emergency medicine. Been doing it for about 2 years now. Graduated 2013 from OU. Been lecturing kind of ever since I graduated from there. Do a lot of lectures in emergency medicine and differential diagnoses, but I think we're going to start branching out and doing a lot more lectures here with you guys, which I'm really excited about. So you'll have to kind of take the caveat with my lectures that a lot of what I say and everything that I do is going to be from an emergency medicine standpoint. With this stuff, I mean, the same thing you'll do in the ED is the same thing you'll see in urgent care, family medicine, depending on the severity, so there's not going to be a lot of difference. But just know that this is not a super all-inclusive family medicine, primary care type stuff, because they do a lot of stuff that I don't really care about. And if I swear every once in a while, I apologize ahead of time. It's just, in the emergency department, I don't mean to do it. If I offend anybody, just get over it. Alright. So, man, it's so weird. I walk around. Do they walk and just kind of sit like this? Alright, I'm just going to stay seated right now. Gotta get more variance here. Okay, does everybody have all this stuff up? Okay. So, bronchitis, bronchiolitis, and croup. What have you guys already talked about here before? I kind of see some upper respiratory type stuff, some of the cerebral RSV here. What lectures have you guys had before?
RSV, pertussis,
Vaguely.
cystic fibrosis.
Bronchiolitis.
Okay, so just a few. Okay. We'll go through all this stuff here, just the objectives that are straight from your thing, so we don't need to go over them. Your curriculum is a little new to me, so we're gonna work through this together and figure out what all we're gonna do. I'm used to lecturing at certain points because I know the OU curriculum really well because I went through there where at certain times during pulmonology we had already had lab medicine, radiology, and all that other stuff, but you guys are kind of getting it all in one big spiel, which good and bad kind of has its things. So if you guys don't understand something or something's not clear, you want further information on it or whatever, please raise your hand, stop me, say, hey, I'm not one of those pretentious professors or lecturers that come up here and say hold all questions till the end or any of that crap. So just stop me, ask questions, even if you think it's stupid, ask it. I'm sure 3 or 4 other people is going to have the same question. So we'll start with acute bronchitis. So with the PowerPoint slides, again, there's more information in your handouts than there are in the PowerPoint slide. We'll kind of just go through these things and start to, go over it. Viral respiratory infection that infects the bronchus and is self-limiting. That's kind of one of the big factors there, that it typically just goes away on its own after about a week or so. Another big deal is viral respiratory virals, the main etiology there. Some of the pathogens are influenza, parainfluenza, bronchitis, rhinitis, etc. So they did a lot of research into this, and there's no significant evidence that suggests a bacterial cause, except for a few selective abnormalities. And these are intubation and tracheostomy. So you're talking about your older, infirm people, your nursing home residents, somewhere where you're, or ICU people, somewhere where you're going to have a high risk for developing bacterial infections to begin with. Again, some of the clinical features of it is a self-limiting inflammation of the bronchi. So, as it says in the name, cough can last 1 to 2 weeks, sometimes longer. You know, you get these people that can cough in on and off, or, you know, been coughing for 3 weeks and it's not getting any better, but they still remain afebrile and everything like that. Typically, that's associated with bronchitis. Signs and symptoms here: cough with or without sputum production, upper airway congestion, rhinitis, chest congestion, wheezing, secondary bronchospasm, so it's not necessarily from an obstructive type situation that you see with asthma. It's more just got a lot of mucus and edema in those upper airways, and sometimes the bronchus tends to spasm and causes some intermittent wheezing, but that typically clears. As well as the bronchi, so that kind of coarse respiratory congestion sounds, usually clears with the cough, because it's the edema and the sputum and mucus is all in the upper airways, so you can pretty much clear a lot of that stuff up there. It's not in your tertiary bronchus or anything like that. Are you guys comfortable with wheezing and bronchi and know what those mean? Yes means yes.
We haven't covered them
We've
yet.
covered wheezing a little bit.
See, I told you guys, if you don't know what it means, ask questions. I'm over here stuff, you're like, okay. So, bronchi are these kind of coarse respiratory sounds. You hear these kind of popping almost peripherally. Just Google what the actual definition for is as far as your physical examination class goes. Wheezing is more of a high pitch sound. You'll see, and it's over the lung fields. You'll hear them mostly in the upper lung fields. Typically, you don't hear a whole lot of wheezing in your lower distal tertiary bronchus. It's more in your kind of upper areas, especially with bronchitis. You're going to see these things. So it's more of a wheezing is a high pitch sound, whereas bronchi is kind of more of a gurgling, popping type sound. It's one of those things that's like hard to explain, but when you hear it, you hear it. And as far as your testing goes, I mean, you just have to know the name, definition, bronchi, wheezing, and know the difference between the two. Oh, by the way, my test questions coming from these lectures are verbatim out of the thing, so, and out of the lecture handout. So the lecture handout, you get 100% on all these questions, so there's no tricks to it. Okay, so here's the big deal from, you know, as you can tell, a lot of these upper respiratory and pulmonary type things, they're all going to be the same, like signs and symptoms, basically. You know, there's cough and congestion and rhinitis, and there's some wheezing and some bronchi and blah blah blah. So your job is PA and as a medical practitioner is to consolidate all that information and try to figure out what it is. So one of the big things with acute bronchitis, is differentiating between bronchitis and pneumonia, because pneumonia will again present with, bronchi, cough, congestion, plus or minus fever. And the two are big differences in treatment between the two. One is most likely a bacterial cause, and the other one is most likely a viral cause. So one gets antibiotics and one doesn't, so this is something you don't want to miss. So here's a chart, or a chart list, whatever. I keep on using this thing here, but obviously you guys can't see that. Stop using it. Here's a chart or a graph or whatever you want to call it that tries to delineate the differences between bronchitis and pneumonia. Bronchitis typically afebrile, lacks systemic symptoms, bronchi, but it clears with a cough, so you'll hear these kind of congested upper respiratory sounds, but they get a big cough and then all of a sudden it clears back up. Do we know what percussion and egophony is? Okay. Gosh, I really should have done more detail on this. I'll be better next time, I'm not sure. Percussion is a physical exam finding with where you're basically tapping to send sound signals through tissues, and the sound signals that you hear when it comes back are different as the air travels through the tissue. So the lung is full of air normally. There's not a whole lot of mucus. There's obviously some blood flowing around through it, but that's really minimal. The lung is mostly air. I mean, the surface area of the lung is gigantic, so it's all air. So you're going to hear mostly these kind of higher pitch sounds whenever you percuss. You guys understand what I mean by percuss? You take your finger and you do one of these things. Yeah. So in a normal lung, you're going to hear these kind of higher pitched sounds. It's going to sound like there's a lot of air in there. It's kind of like you're thumping on a watermelon. You know, it's not dull. There's a lot of air. With pneumonia, you're talking about a peripheral pulmonary infiltrate within the alveolar bodies themselves, is that there's bacteria and edema and mucus and everything all around that lung field that's consolidated. And so whenever you thump over that area, it's not going to sound high-pitched, it's going to sound very dull. It's going to be a very low-pitch and low resonance type return. And so that's how you kind of help differentiate between an area that has a lot of what we call consolidation, which that dullness to percussion, we call understanding dullness to percussion. Okay, you might see that sooner or later here. You know, would be one of the main differences. That egophony again is it's a physical exam technique that you do where you have the patient repeat these high-pitched sounds. Usually it's like E, 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 A, 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 and the difference between the, put your hands on their chest, and you can feel the difference of the sound coming into their lungs and how the sound of the air within a normal, well-aerated lung is going to, again, be more high-pitched versus the sound that's less aerated lung, more consolidated, is going to be more low-pitched. And this is a pretty poor explanation of percussion egophony, so just go and look that up on your own. It's very easy to understand. How often do I percuss and do egophony? Ever? I don't think I've ever done it once. But, you know, if you're like in the mountains and you don't have a chest x-ray or stethoscope, these are good things to do. You know, these are all the kind of old school ways that we used to figure these things out before we had modern technology, so, but it's good to know. And lab work for acute bronchitis is typically unremarkable, and pneumonia, you're going to have some abnormal labs, white blood cell counts, things like that. And then again, on the contrast, you typically, whenever I say typically, that means, you know, nothing in medicine is 100% ever. So typically you have fever, but sometimes you may not. Systemic symptoms with pneumonia, chills, rigor, lack of appetite, altered mental status is what AMS means. Bronchi, growls, decreased breath sounds, that goes along with the consolidated type picture. Again, dullness to percussion and abnormal lab work. Does that make sense? About how differentiating between these two? Okay, so achieving the diagnosis. You know, acute bronchitis is mostly clinical diagnosis. You really don't need any lab or radiology to help you figure it out. You can go based on symptomology and patient presentation, physical exam findings, and achieve your diagnosis. You know, one of the things that has always been said, you know, and I believe is true, is that you can get to probably about 85% of your diagnosis just based on a good history and physical. You don't need any of the fancy CTs, X-rays, MRIs, or lab work that we have nowadays. Those are all helpful, but taking a good history and physical and learning how to do those is going to get you to about 85% of your diagnoses before needed. So chest X-ray is something that we use as an adjunct to help us diagnose acute bronchitis. You don't necessarily need it to diagnose it, but if you have some questions on to differentiate between bronchitis and pneumonia, like I said, you know, egophony and percussion here, dullness on percussion is, you know, those are kind of more old school things to do, and you know, you have to have a very fine-tuned physical exam skill to be able to differentiate those two. So chest X-ray is helpful to get you to the right answer. And these are just some findings that you'll see on the chest X-ray for bronchitis, perihilar congestion, and non-specific findings. I mean, they're just kind of some weird things there, but nothing that definitely tells you whether that's pneumonia or anything like that. And pneumonia, you'll see consolidation and interstitial infiltrates. More to come later, so we'll kind of talk a little bit about that more. So the big thing here is when to order a chest x-ray. So this is, I mean, this is like one of the bigger things. These three lecture topics don't really have a whole lot of lab tests to do with it. It's more just history and physical. But this is your responsibility as a medical professional, is to get that. It's, you know, it's easy to answer a test question on a piece of paper when they give you everything you need. The CBC is this, the chest x-ray looks like this, the CT says this. I mean, that's a piece of cake. Anybody can do that. You can take an undergrad and do that. You don't get this unless you order it. So if you don't get the chest x-ray, you're not going to see what it shows. Or you don't get the white blood cell count, you're not going to see what it shows. So part of the diagnosing and knowing what to do is figuring out when you need to order those tests. And you obviously can't order a full workup on every single patient that comes in, because then you're going to be bogged down, and you're not going to be moving patients in through there and everything like that, and the cost and time that's associated with those. So when to order a chest x-ray, abnormality of vital signs. So why do you think they call them vital signs? I can't hear anybody.
They're important.
They're important, yeah. I mean, it says the word vital in there. I mean, that's, vital signs. They're important. This is something that gets overlooked so much as students and even professionals, doctors, PAs, nurse practitioners, nurses. These are things that get overlooked so much because, unfortunately, they're done on everybody. Everybody that comes into a primary care clinic or endocrinologist or whatever place you go to gets your basic vital signs. So you're always seeing them there. So it's easy to forget about them or pass them off to the wayside and not pay any attention to them, or you're more focused on trying to obtain an accurate diagnosis and everything like that. These are so important. These will make or break you, especially in emergency medicine. They pay very close attention to these and make sure that you're getting accurate figures. A lot of nurses and things like that. And I can talk bad about nurses because I was one. I was an ER trauma nurse before I went to PA school. But if you were not a nurse, you can't talk bad about nurses. That's just an unspoken rule. I'll let you guys know that. If you go on rotations and start bashing nurses, you're going to make your life hell. But if you were one, you can say your piece, but you know that you don't do it anyways, because then you're still making your life hell. But a lot of times, like I said, the things that you do over and over and over again become routine, and they stop caring about them. They don't take the time to get an accurate temperature. They very quickly measure someone's heart rate based on a pulse oximeter, and it's not accurate. So you've got to take it into account a lot of times. If somebody just walked 100 yards from the parking lot and they weigh 400 pounds, and they go straight back to the room and get put on a pulse, their heart rate's going to be 120. I mean, they're out of shape, and they're, and they just walked 100 feet. Does that mean that their resting heart rate's 120 because they're sick? Probably not. So focus on your vital signs and make sure that they're accurate. And this is gonna, so back to the topic here. I go on tangents a lot, so I have to apologize. When to order chest x-ray here: tachycardia, heart rate over 100, tachypnea, respiratory rate over 20, fever over 38 C, or hypoxia is a pulse oxygen saturation less than 92%. 93 to 100 is about normal. So if they're hypoxic or they're febrile, so when we talked about the differentiate between the two. So bronchitis is typically afebrile, but not all the time. You can still have a fever with a viral infection. That doesn't mean you have pneumonia. But whenever you have a fever and then have all these other symptoms here, it's a little more difficult to differentiate between the two. So that's why we go to a chest x-ray to help us figure that out. Does that make sense? Everybody cool with this slide? Okay. Everybody cool with this right here? Yeah? Good, you might see that soon. Okay. So here are a couple x-rays. One's bronchitis and one's pneumonia, obviously. So to the lay person, it's obviously pretty easy to see which one is which, because really obvious, a lot of times it's not quite so obvious. Have you guys had any lectures on how to read a chest x-ray? One, good, okay. That's all we got too. And this thing, reading chest x-rays is, all about repetition, seeing enough of them, reading thousands of chest x-rays, you get better and better at it each time. But the things that you need to make sure that you do, I'm sure they told you about, is going through and reading a chest x-ray the same way every time, because you're responsible for every single thing that's in this image. Somebody's coming in for cough and congestion, and that's all they want to be seen for, but have a distal clavicle fracture because they fell a couple days ago, you're responsible for that distal clavicle fracture right here. Whatever way you decide to read your x-rays is up to you and whatever you want best. I don't do the whole ABCD, airway, the lungs, and the cardiac, and the bones, and all that stuff like that. I don't really follow that much, so what my suggestion to you is whatever you decide to do it the same way every time. And there's a few key things that you need to, I hate that that's on there, so I'll do this. There's a few key things that you need to make sure that everybody,
That doesn't work.
There's a stick.
There's a stick somewhere.
Yeah, that laser doesn't work on these screens.
Oh. This right here?
Yeah.
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 Dr. Lee's stick.
That's fine. Okay. So, as far as differentiating between pneumonia and bronchitis, we're looking for consolidations. So we want to look for any areas of the lung fields that are obstructed by our view. So this is a pretty normal chest x-ray here. This is, bronchitis, but you can see this a lot in normal people that don't have bronchitis either. You have some, a little perihilar, so this is your hilum right here, where both your pulmonary arteries and veins and your bronchus and everything comes out right here and splits going into each of your secondary and tertiary bronchus. A little perihilar congestion here, so you can see that this area here is a little more congested than this side. So whenever you're looking at x-rays, symmetry is one of the most important things you want to see. Everybody has symmetry. Both sides of your lungs are supposed to be the same. This is supposed to almost kind of look like this side except for the elevation diagram of your liver. But as far as like this area of your lung is supposed to kind of look like this area. So to differentiate between symmetry is helpful to define consolidation. So you can see that there's a little perihilar congestion here compared to this area here, right? Everybody see that? So look for your cardiac borders that are unobstructed on this one. Look for your hemidiaphragm sections here, they're unobstructed. You can see it very, your costodiaphragmatic sulcus here, and costophrenic sulcus here, your lung apices, making sure that your lungs are well aerated and go all the way out to the periphery, which I'm sure they talked all about there. And so now we go to this one here, and you can see how you can't really make out this heart border like this. You've lost symmetry. So you can see this heart border very well, you can't see this heart border very well. As opposed to this one, you can see both sides very clearly, and they're very well defined, marcated. This one, you can still see the diaphragm here, which is good. And you can still see one here. So what would this be as far as what lobe?
Not right middle.
Right middle.
Right, because it's not obstructing the diaphragm, correct? But it is obstructing to the right heart border. So you can tell the difference between these two is this is an obvious consolidation, and this is more just kind of congestion and a little bit of a mucousy type edema. Right? Is everybody good on these two chest x-rays and about how to differentiate between the two, between bronchitis and pneumonia? And it's not always going to be like this. I mean, this is obviously a really bad pneumonia, but going through and looking at your indicators there is helpful. Okay, so now the lab. Like we said before, you really don't need a whole lot of lab or x-ray to achieve this diagnosis. If you wanted to, you can get a white blood cell count. Have you guys talked about hematology and white blood cells and infection and immature neutrophils? Great. So it's an imperfect test, And higher low does not necessarily make the diagnosis. So just because you have a high white blood cell count does not mean you have a bacterial infection. Just because you have a low white blood cell count doesn't mean you do not have a diagnosis of pneumonia or bronchitis. So, white blood cells is one of those things that kind of just, you gotta learn how to interpret it because it's not black and white. Do you guys talk about what can cause an elevated white blood cell count in the absence of infection?
Yeah.
Yeah, good. Okay. What are some of those? Stress,
Burns.
burns, steroids. Steroids will do it a lot. You guys haven't had pharmacology yet, so steroids will cause an elevated leukocytosis a lot, as well as stress and high burns, and that all kind of goes against the whole cortisol release and the demarginalization of white blood cells from the lining of the vessel, but we're not going to talk all about that. That's for another lecture. Another test you can do is procalcitonin. You guys can see that. Procalcitonin here. This is helpful to distinguish between viral and bacterial etiologies. It's mostly used as a sepsis criteria to differentiate between sepsis and severe sepsis, but it's also helpful in the use to distinguish between viral and bacterial etiologies. So you have somebody that has an equivocal chest x-ray, meaning that you can't quite say yes or no either way. They have a fever and their chest x-ray looks iffy, but everything else looks pretty good, trying to decide between this is a bacterial or a viral cause, pneumonia or bronchitis. Procalcitonin is helpful in getting that. A really low procalcitonin level will be more towards a viral etiology, and a higher procalcitonin level will be shooting more towards a bacterial etiology. And you can kind of look that up on your own about the pathophysiology behind procalcitonin. Just suffice to say that low it's viral and high it's bacterial. So yeah, less than 0.5 represents a viral etiology. I think the upper limits is 2.0, so anything over 2.0 is more of a bacterial etiology, and then you're starting to get into kind of borderline sepsis. Treatment. All right, so now to what we do. Treatment for acute bronchitis is symptomatic, and it's purely what it is, just taking care of the symptoms. NSAIDs, Tylenol, ibuprofen, naproxen for fever, muscle aches, body aches, things like that. A lot with children, you're going to have them, they'll just make them generally feel better. Decongestants, pseudoephedrine, and phenylephrine, other drugs like that, those are all in your handout. I don't want to go over the pharmacology too much because you guys should have that in class here, and pharmacists will detail out that much better detail than I can. Antihistamines, antitussives. So antitussives, that's kind of a sore subject for me. I know that there's not a lot of research behind whether or not antitussives are helpful. I mean, it's obviously not going to be helpful in clearing the virus from your blood at all, or from your respiratory tract, but it's going to help make you feel better for these people that are coughing their heads off. I'm not a primary care guy, so whenever I see my patient for, this person I'll probably see for about 3 minutes in the room, and then they'll go home after that. I don't really have to see them come back or anything, but I am kind of more of an anti-tussive type guy. I don't like cough suppressants. I think that a cough is a physiological reflex mechanism to help prevent pneumonia. You're coughing so that you can mobilize mucus secretions out of your respiratory system and get all the viral shedding that is in that mucus out of your body so that it doesn't just sit there and replicate. I think antitussives suppress the cough reflex, and a lot of times I see, especially in older people, I'm completely against it. If you've been coughing, if you had bronchitis for 2 weeks, you've been coughing every night for 2 weeks, and you can't talk, and your voice is sore, and you can't swallow, and all that stuff, we'll go ahead and give you some antitussives. But other than that, I always tell people that cough is a protective mechanism to help from giving yourself pneumonia. Mucolytics help mobilize mucus secretions in the upper airways. Sometimes they work, sometimes they don't. Bronchodilators, so albuterol, beta-2 agonist that helps dilate your bronchus, is helpful for people that say they're a little short of breath or having some associated bronchospasm, wheezing. Steroids, whenever I was doing the research on this stuff, that, they really bashed steroids and said there's really not a whole lot of place for them. But anecdotally, steroids are helpful to reduce upper airway inflammation and kind of just in general making you feel a little bit better. But it's not necessarily the mainstay of treatment. And of course, all your other stuff, increased fluids and, getting a good night's rest and all that other junk is helpful as well. Any questions on this? No, pretty sure it's core stuff. Antibiotics. Don't do it. Capitalize that and put a lot of exclamation points because I'm serious. Don't do it. Don't contribute to the proliferation of antibiotic-resistant bacteria. One is that, it's going to kill, we are all going to die from bacteria that's resistant to antibiotics. You guys laugh, but I'm serious. We all in this classroom, when we get 16, 17, we're all going to die from it. And it's going to be your fault for prescribing antibiotics to bronchitis kids. So don't do it. It's viral. It's a viral etiology. All of the top 5 or 6 pathogens things are all viruses. Okay. Now that I just browbeat you into saying never give anybody antibiotics, I'm going to tell you the reasons why you should give somebody antibiotics for bronchitis. The old or infirm, again, those people that we talked about, those old nursing home people, those people that are in the ICU or have some kind of weird, is this a touchscreen? Oh, that's so sweet, sorry. Those weird people that have an artificial airway, like a tracheostomy. You guys familiar with a tracheostomy? So it's a tube that goes through your trachea and helps you breathe. It's for a lot of people that have upper airway issues. You see a lot of nursing home patients with that are either super obese and can't breathe, or COPD, or for whatever reason have trouble bringing air in. Those people are at higher risk for a bacterial infection because there's obviously, you're bypassing the cilia in your respiratory system that normally bring mucus and stuff like that out and bring bacteria out. You're bypassing that area by just going directly almost into your mainstem bronchus. And symptoms greater than 7 to 10 days. And this is not necessarily that they have a bacterial infection, it's that you're preventing a occurrence of a bacterial infection. So they've done the research and said that it's 7 to 10 days worth of cough, congestion, things like that. If you're not clearing those secretions after then, they're just sitting in your lungs and your mainstem bronchus. You're just providing a breeding ground for respiratory bacterial pathogens to propagate. So after those times, it is indicated to give antibiotics after that. In looking at your handout, do I have a list of antibiotics that they go over? Okay, that due to this type of pathogens. Okay, and we're not going to talk a whole lot about that. Like I said, because we're going to let your pharmacology people talk about that. But it is in your handout. There are not going to be any antibiotic questions on your exam as far as the ones that I wrote. Selection of antibiotics used to treat common upper respiratory pathogens, so strep pneumo, H. flu, and catarrhalis. All right, you guys heard all those yet? All right, let's say them all together. Ready? Strep pneumo, H. flu, and catarrhalis. One more time. Strep pneumo, H. flu, and catarrhalis. Third time strong. Strep pneumo, H. flu, and catarrhalis. So now you have zero excuse if you guys ever rotate with me and I ask you a common upper respiratory pathogens for ear infections, for bronchitis, for sinusitis, for all that other crap. You have zero excuses for why you don't know that. And if anybody ever asks you on rotations, there's zero excuse why you don't know that because I had to repeat it 3 times. Strep pneumo, H. flu, and catarrhalis. You're going to see those over and over and over. And you guys had ENT already, right? So. Right, good, okay. So and again, see handout for the specific antibiotics. I said, we'll discuss more pneumonia, because when I wrote this, I thought that I might be lecturing over pneumonia, but that was already covered, so we will be discussing antibiotics into, I hope, a much further in-depth detail whenever we go over pneumonia, because those are obviously the mainstay treatment, and those are most important about antibiotic selection. Okay, anybody have any questions over acute bronchitis? I mean, pretty straightforward stuff, not a lot of extra special tests to interpret. Getting your good history and physical exam is going to lead you to the right way. So it's good. Everybody all good? Yep. Okay. All right, bronchiolitis. We're just moving on down the respiratory tract here. Lower respiratory tract infection resulting in edema, mucus accumulation in the small distal airway. So this isn't necessarily an alveolar infiltrate that's in between the alveolar airways. This is still in the bronchus, hence the term bronchio. It's in there, but it's in your further distal tertiary bronchus. So you have your main stem, secondary, and tertiary bronchus, right? I mean, I'm asking, it's been a long time since I've had anatomy, that's right. Good. Man, you look just like your brother, it's freaking me out. You're Dr. Brown's brother? Yeah, okay, anyway, sorry.
I was like, oh.
I worked with him.
Yeah, I was like, okay.
Anyways, okay. So small distal areas, so a lower respiratory tract infection resulting in edema, mucus accumulation in small distal areas. Well, you might see that later on too. Andy's not seeing it, is she? Okay. I'm not trying to spoon feed you guys test questions, but
That's okay.
I'm sure you guys have a
I
lot.
like that.
Keep it coming.
Yeah, I'm gonna get, guest lecturer of the year. I give you all the test questions.
Yeah, we do have to write a review every year, so.
This can go one of two ways.
We're just letting you know if you want to do it.
Yeah, nobody likes it.
I mean, this stuff is, it's all pretty simple. It's all in the handout. If you study the handout, you're gonna get all the questions right. This stuff isn't the most complicated thing to go over. But it is important because you see this all the freaking time, especially bronchiolitis in your certain seasons. So viral etiology is the most common. Respiratory syncytial virus is the most common virus that causes bronchiolitis. I thought it was kind of weird that you guys have a lecture over RSV in and of itself and a lecture over bronchiolitis when those two are basically go hand in hand. When you say RSV, you mean bronchiolitis. And when you say bronchiolitis, you mean RSV. They're basically the same thing. Now, obviously, there's going to be other respiratory conditions that RSV may cause, but when you're talking to ED or primary care or pulmonologist, whatever, you just say they have RSV. They know you mean bronchiolitis. Those two go hand in hand. There are a couple other viral etiologies, paraflu. RSV is by far the most common viral etiology, bronchiolitis.
So does that mean bronchiolitis occurs in little kids?
Absolutely, we're going to
More
talk
often.
a lot about that. Yeah, you don't see bronchiolitis in adults. Typically affects infants and children under 2 years old and predominantly in the fall and winter season. So when you're on rotations and stuff like that, hopefully you have a ER rotation or a primary care rotation in the fall or winter seasons. So you'll see a lot of bronchiolitis. You don't see a whole lot of RSV outside of that for whatever reason. Kids are inside more and they're all clumped together and they're just little, viral factories that they just infect each other, which is good though. I mean, I'm all for kids, ages 2 to 4 getting sick basically their whole time between them, because after that you develop a lot of good antibodies and a strong immune system that you don't get sick when you become an adult. So if any of you guys have kids from 2 to 4, just try to get them as sick as possible. And then you won't have to worry about them when they're teenagers because they're going to have a strong immune system. I mean, all the parents are like, yeah, right. Anyway, so yes, you rarely see RSV in people older the age. I think the oldest one I've ever seen was 6, and older than that, is typically unseen because you are exposed to respiratory syncytial virus and rhinovirus and stuff like that so much whenever you're a kid that your body develops antibodies to it. You don't get it when you're an adult. Risk factors for this: prematurity, born less than 37 weeks, under 12 weeks of age, or congenital disease or immunocompromised. Those kids are going to be at greater risk for developing RSV and have worse outcomes for it. So pathogenesis here: terminal bronchial epithelial cells are damaged by the virus, resulting in inflammation, edema, mucus, and sloughed epithelial cells that crowd the airway, leading to obstruction. This is the main pathogenesis behind bronchiolitis, which causes a lot of your symptoms. So clinical features of it typically starts with upper respiratory symptoms, rhinorrhea, congestion, cough. Those are typically within like the first 24 hours to 2 days. 1 to 2 days you'll see those. After that, symptoms progress of fever, cough, and worsening respiratory distress, depending on the severity of the illness. So kind of little prodromal symptoms. You guys know what prodromal means? Yeah, prodromal means before the illness starts to take effect. So little these kind of prodromal symptoms for 24 hours, and then after that you have the true onset of the symptoms that occur from the pathogenesis of it. So the fever, the cough, and the respiratory distress are from the obstructive distal airways from the edema and slough of epithelial cells. More clinical features. So signs of respiratory stress. I think you guys almost have kind of gone over that a little bit here. Right here, right? Are you guys all familiar with these? Wheezing, crackles, tractions, nasal flaring, tachypnea? Okay, we're all familiar with that. Good. These are part of your physical exam. And you know, a clinical caveat to these things is you got to make sure to take the infant's clothes off whenever you're doing the exam. So most of the time you're going to be examining these kids, you know, 6 months to 36 months of age. You know, they're young kids. They're going to be in like these full onesies or whatever. They're going to bring it in, and you know, and it's easy to listen over the lung sounds, but it's going to be very difficult to see intercostal, supraventricular, abdominal breathing when they have clothes over. So you got to disrobe these kids, you get them on a bed, and take a very good look at what these kids look like as far as their breathing profiles go. Nasal flaring and grunting are also very important there. Those you'll see more because you know they're not going to be covering their face. And then tachypnea, obviously, the respiratory rates in the 50s and 70s. That's going to be different depending on what age group you are, because the younger you are, the faster your resting respiratory rate is, and the older you get, the slower that tends to go. So know the different vital sign ranges as far as respiratory rate and heart rate goes for pediatrics. And I guess you're not pediatrics yet, but that's something to know. Associated complications you have with this: dehydration and respiratory failure. You know, they're dehydrated because you're not eating and drinking, because they're expending all their energy on breathing, and you know that's more important than eating. Any questions on that? Okay. I have some videos here that have a hard time coming up, but we'll look at them here. So this is subcostal, intercostal retractions and respiratory stress, and we'll kind of look at how this kid is breathing here.
Here at the angle of the ribs, this is what I call retractions. Now the baby's not showing any nasal flaring, which is another sign of distress. And one of the other things we'll look for is over here in the neck. Make sure that she's not doing suprasternal retractions, which is, you can see them and pulling. So it's really just here. And if she coughs while we're here, you'll hear it's like that kind of a cough. And that's
okay. So you guys can recognize whenever kids coming back there. She had a little bit of abdominal breathing right here. You're always going to have a little bit of abdominal breathing when you have these lower intercostal retractions here. You can see a lot, they're using their abdomen kind of in and out to help facilitate pulling in the air, because you guys all know that when you breathe, your diaphragm contracts and flattens out. That's what causes the negative pressure. But when you're having trouble pulling air in from an obstructive bronchus, you need all that negative pressure that you can do. So moving that abdomen in and out also helps create and facilitate a little bit more negative pressure. You're going to see that a lot. This kid right here, so this is some more just intercostal and supraclavicular retractions. This kid here, if you see this, you're looking to tube this kid quick. You're looking to intubate him with an endotracheal tube and provide an airway, because this kid's fixing to die here pretty soon. And you can tell just by the setting here, he's obviously in the operating room or in a critical care room where I think they're fixing to do that. We don't see it, but I think basically just listening to the sound of it and everything like that, he's very much hooked up on monitors and is fixing to be intubated. So this is what a very distressed kid looks like.
Get ready first.
So if I saw that in the ER, you guys see that, you should be pooping your pants right then, because that's serious business. That kid's gonna die here pretty soon. Did you guys hear the sound of the beeps in the background? Whenever you can tell this is in the operating room, but some of the monitors and stuff like that will have a setting that the lower the tone of the beep is indicative of the oxygen saturation. So you guys can hear it from the very beginning. It starts off kind of a higher, it's the faster beat. Starts off in a little bit higher beat, but as you can see, it starts to get lower and lower, and you listen to it. This is this kid's oxygen saturation going down.
Get ready first.
So that was probably about a 20-point dump in oxygen saturation. I'd say that kid's probably sat around 70% or 60%. That's pretty bad. But this is what they'll come in, and you don't whenever you see this, you don't sit there and talk to the family or ask your history exam. Whenever you see somebody come like that, you're getting an airway and you're doing that first thing. You'll learn about the ABCs of emergency medicine when you start going there, and the A, that's first way airway, is the most important. So this is a very sick kid. So you can see the difference between this, who's in a pediatrician's office, she's kind of retracting a little bit, struggling a little bit to breathe, but didn't have any acrocyanosis of the hands. When you looked at her lips, she wasn't looking like she's in terrible distress compared to this kid who's about to die. So there's obviously a continuum between those two. There's going to be a lot of people in the middle between that. So, and you won't. This I hope you wouldn't miss with the guy's shirt on. But this is the reason why you need to expose these kids, because you wouldn't see those intercostal retractions if she still had this onesie on. So it's very important to disrupt those kids. Okay. Everybody cool with all that? Okay. Diagnosis bronchiolitis, chest X-rays not routinely needed, used for severe cases sometimes. Patchy infiltrate. So that kid, the first kid that had a little bit of retractions, I'd go ahead and get a chest X-ray on her. But this kid's just coming in cough, congestion, runny nose, a little bit of a fever. They don't necessarily have a positive RSV, but it's not having any trouble breathing. There's no alterations in their vital signs. You don't necessarily need to get a chest X-ray on those kids. As far as her findings, she said this kind of patchy infiltrate with some perihilar congestion. Peribronchial cupping is pathognomonic with bronchiolitis. We'll go over what that is. If you see the words peribronchial cupping on an exam or board question or something like that, if RSV is the answer, if RSV is an answer selection, I would choose that. There's obviously going to be some more selected disease processes that cause peribronchial cupping, but RSV is one of the main ones. Lab tests, so RSV rapid antigen test. It's a nasal swab. It's real quick in some places it takes a little bit longer. Quick, non-invasive, you just get a bunch of upper respiratory nasal secretions, a nasopharyngeal swab, and they test it, and you can see the virus associated on that. And other tests used for associated complications. So that kid that, the second kid that comes in, you're obviously, you want to get a little bit of blood work on him. And for kids that look like they're dehydrated, they, dry mucous membranes, sunken fontanelles, tachycardia, and these other signs of dehydration, you want to get some CBC and BNP to check for electrolyte abnormalities or kidney function. Do you guys go over BNP at all? Basic metabolic panel. We won't go over that, we'll do it at another time, but those are some other exams you need to do. You won't need to know for this test. Okay. Oh God, it's gonna be so hard to see. Oh, maybe we can do it here. All right, I don't know if you guys, let's not do it on this one. The arrow isn't pointing to this. This is a oxygen cord, a nasal cannula oxygen cord that's just overlaid over the x-ray, so don't pay any attention to this. So again, you have some perihilar congestion right here. Don't pay any attention to this because this is just an oxygen cord. This is a piece of material that's sitting outside the chest. So the trouble with x-rays is it takes a three-dimensional image and compresses it into a two-dimensional format, so you don't get depth with an x-ray. So things that are sitting on top of the chest, appear in the same place that are behind the chest. It just flattens it out. So you have to take that into account for whenever you're looking at these things. Again, a little perihilar congestion here. Oh, good, okay. Peribronchial cuffing, this is it right here. So you see this, so now what you're looking at is a direct head-on view of a tertiary bronchus. All right, so it's just a very small distal airway. And normally, you shouldn't see that airway because it should be full of air. You can't, the tissue around it is so small and tiny that the x-rays don't, the x-rays permeate it, they don't collect around it, so you shouldn't see it normally. So you have these small ones all over the place here, but you can't see them because they're all full of air. This one you can see really well because there's so much slough, respiratory ileal cells, and mucus and edema, is that it calculates that the diameter of that airway there. So these are kind of these head-on views of peribronchial cuffing, which is, again, abnormal for RSV. And again, on this one, you see the perihilar congestion here. And again, if you can kind of just look at it straight on, you can see a little bit of peribronchial cuffing here, a little bit here. I mean, it's obviously not as pronounced as this. You can see these tertiary airways right here that have that mucus edema around it. And again, here we're not seeing any infiltrate, right? Maybe a little bit right here, that's kind of iffy. But you can very clearly see the heart borders on each side, the diaphragmatic recesses, and the diaphragm are very non-obstructed. You got well-aerated lungs on the periphery here. So I wouldn't call this a frank pneumonia, consolidative pneumonia. This is more indicative of bronchiolitis. Can we all see the difference between the two? Yeah, does everybody understand peribronchial cuffing and the reason why you get it? Okay. All right, severity assessment. This is the key on bronchiolitis, between the difference between that kid that we first saw in the picture that was not in a whole lot of distress versus the kid that was fixing to be tubed. Like I said, there's a continuum between those two. There's a lot of people in between. So frequent reevaluations are needed to assess the improvements or decompensation of these patients, and they will turn on a dime. They'll start out looking normal, then all of a sudden just, kids and old people do that a lot. They will start out okay, and then they will decompensate quickly. They just don't have a lot of reserve. They don't have a lot of respiratory reserve. So that whenever things start to go bad, they start to go downhill very quickly. So these aren't one of the kids that you can just go in and see and see them once and then say, oh, they got RSV, and then give them a breathing treatment and send them out the door. These are kids, depending on the severity of them, they need constant reassessment. Sometimes, with those really bad kids, I won't even leave the room for 30 or 40 minutes. I'll just be constantly sitting in there, watching them, how they do. Indications for hospitalization, toxic appearance, they're lethargic, dehydrations, they're dehydrated. So toxic appearance is a kind of a listless infant or child, one that's not wanting to move, one that when you mess with them, they're just so worn out and have such decreased respiratory capacity and sick that they just don't want to do anything. They don't want to eat, they don't want to move. When you get an infant that's not crying and not fussy whenever a stranger is in there jacking with them and the nurses, that's typically not a great sign. There are some like really great babies that are, that love people and everything like that, but you can tell when you get a normal baby versus somebody who's looking sick and that just doesn't even want to mess with anybody. That's more of a toxic appearance. Moderate to severe respiratory distress. The classification of these moderate to severe respiratory stress is difficult to say. I tried to find some charts or a lot of consensus on what is moderate versus what is severe. Not a whole lot on there. Obviously moderate, you're going to have retractions and difficulty breathing. Severe is, I think the worsening and have low oxygen saturations and maybe a slower respiratory rate. That means their drive is going down and that they just can't keep up. So differentiating between these two is kind of difficult, but it's more of an anecdotal, clinical type thing. The more you see somebody who's in severe versus moderate. I would say the first kid that we saw on the YouTube video is more of a mild to moderate respiratory distress versus obviously the kid on the second YouTube video is severe respiratory distress. Hypoxia, the need for supplemental oxygen issues. I don't know what this is. Need for supplemental oxygen. So a hypoxic kid in moderate respiratory distress, these kids need to be admitted to the hospital for further symptomatic care and monitoring. So treatment again is broken up into two different segments: non-severe, so these are the kids that just have nasal congestion and fever and cough, but they're not respiratory distress. Their vital signs are normal and they look good. It's symptomatic care because it's a virus. Antibiotics won't do it, so don't give them antibiotics for it. Nasal suctioning is really key for these kids. The more bronchiolitis and RSV you see, the more you can kind of tell on which ones are going to be positive or not. And I would say, kind of anecdotally from the patients that I've seen throughout the past couple of years in my practice, is that these kids have a lot of rhinitis. They're just snotty, and it's pouring out of them all over the place. And those are the kids that are most likely going to be RSV positive versus the kids that kind of have a little bit of cough, fever, and congestion, but they're not having a whole lot of mucus production. I see those kids typically don't have RSV. So nasal suctioning is going to be real key for these things. Just getting into the nasal bulb suction syringe. You can do the normal saline and kind of squirt it up in there and suction it out to help clear all those upper nasal congestions and help them breathe, and they feel a lot better. They fight you on it, but it needs to be done, and that's one of the things that you need to tell parents as far as anticipatory guidance is that you have to do it. A lot of new moms and things like that, they think their baby's going to break if they touch their nose or anything like that. You're just like, hey, get in there, suction them out, and really get in there and try to clean it out. Really helps. Increasing fluids and monitoring the eyes and nose. So how many times should an infant go to the bathroom in a 24-hour period? Why would you guys know that you haven't had these yet? 3 to 4. 3 to 4 wet diapers in a 24-hour period is kind of the lower limits of normal as far as dehydration goes in the kid. So it's kind of difficult, so, it's like, well, how many, ounces have they been eating if you don't got a parent that